Yeah, it looks good.
Perfect. So thank you for the opportunity to present. I'm going to present on antigrade strategies and how the field has advanced over the last couple of years. So this diagram basically highlights some of the different strategies that we can use in order to address CTO PCI through an antigrade strategy. As Darshan was mentioning earlier on, as the CTO becomes more complex through the JCTO score or any sort of scoring system, we start relying more on retrograde strategies. But I feel that the antigrade field approach has advanced to a point that we're allowed to tackle more complex CTOs without necessarily resorting to retrograde PCI. So as per the Progress CTO registry, the antigrade wiring approach remains the most common approach used primarily in about 69% of cases, associated with the technical and procedural success of approximately 88%. And through new strategies, we're able to tackle antigrade CTO PCI in more complex lesions. And this is highly based on imaging, whether it's CT coronary angiogram guidance or IVUS, targeted wire-based dissection reentry, which I'll highlight in future slides, and then use of novel device-based reentry. So when it comes to IVUS guidance, an ambiguous proximal cap can definitely make a CTO PCI more difficult. And as a result, is one of the potential characteristics of the CTO PCI that may push an operator to pursue a retrograde approach. Now, with the use of the eagle eye, we're sometimes able to effectively identify the proximal cap, and often the proximal cap reveals a shorter CTO than one would have envisioned, as well as a cap that is not very calcified. So this is an example of where an eagle eye was used to identify a proximal cap. Here's a proximal CTO of the RCA, and there was a branch that kept on basically limiting antigrade wire escalation as the wire would keep on going into that branch when we were trying to penetrate the proximal cap of the CTO. In order to identify the proximal cap and prior to converting to a retrograde strategy, we used a workhorse wire to deliver an eagle eye into the side branch. And then we were able to identify where the proximal cap was, and it seemed like a pretty viable antigrade wire escalation strategy. And then through a second wire, we delivered a turnpike spiral and then used Pilot 200, which was initially unsuccessful. And we escalated to a Gaia third, which allowed us to penetrate the proximal cap of the CTO. Because the eagle eye basically is manual deployment, here on this IVUS, you can actually see the eagle eye in the side branch. And as we pull back, you'll see the proximal cap of the CTO coming in at about 4 o'clock. And you can see that the wire penetrates the proximal cap at about 4 o'clock. And we get a lot of information here, not a lot of calcification in the proximal cap. And we can see that the wire appears to be true lumen in that area. With this information in mind, we were very comfortable in advancing the turnpike spiral. There was a little bit of a tortuosity in the mid-segment of the RCA, so we de-escalated to a Pilot 200 to try to traverse that part of the CTO. And then ultimately, if you look at the cine on the right, we're able to identify that the distal part of the wire was in the true lumen. And this is what the CTO PCI looks like at the end, with no need to resort in this situation to a retrograde strategy. The beauty of it is that the procedure, as Darshan was mentioning, often retrograde PCI can take longer, more radiation. This procedure actually started and ended quite quickly, and again was mainly guided by the use of IVUS to identify the proximal cap, and essentially converted what may have been a complex CTO PCI into an antigrade wire escalation procedure. The other part that's important is to use IVUS to identify the optimal point of reentry. So the optimal point of reentry is very important because you need to ensure whether you're going to commit to stenting versus doing an investment procedure. And in addition, there's new data suggesting that loss of side branches, important side branches, which were defined as branches more than 1.5 millimeters in diameter, can lead to increased MACE at 5 years. So here we have a CTO PCI, again, of the proximal RCA. You can see that there's retrograde collaterals from the circ, but they're mostly epicardial and don't appear very palatable. This CTO PCI was attempted about 2 times prior by a CTO operator and then referred to our center for a third attempt. I wasn't the primary operator initially. You see here that the plan was to basically try an Antigrade approach again. A 7 French JR4 was chosen, which made the procedure a little bit more difficult because of the lack of support. They tried penetrating the lesion with a Gaia. You can't really see it too well from the cines, but in the distal RCA, there was quite a bit of calcification. And they were unable to penetrate the calcification with wires. They kept on going into the subintimal space. And as you can see on the cine on the right, there were some issues with support. Even with the guide extension, the 7 French GR4 kept on being pushed back. They also attempted to deliver a recross, and then ultimately I was asked to help by trying to deliver a stingray into this lesion to see if we could re-enter below that chunk of calcium. So I too found that it was very difficult to re-enter or to actually move the wires through that calcium. So ultimately I attempted to knuckle a wire, which is successful in getting me into the subintimal space, into the distal RCA. But as you can see on the cine on the right, we were in the subintimal space, just proximal to the crux of the heart. And we definitely wanted to preserve that PDA. We tried again to deliver a recross and also tried to deliver a stingray, but were unsuccessful. So we ended up using a Gaia third to try to re-enter the true lumen through a wire-based approach. As you can see on the cine on the left, we get an impression that we might be true lumen. And then on the cine on the right, we also suspected that we could be true lumen in a side branch, but we weren't entirely sure. As the procedure progressed, we started losing retrograde visualization. We were wondering that whether we had extended a dissection and whether we should abort the procedure. But just at the very end of the procedure, the wire, which I believe was a pilot 200, ended up going into what seemed to be a retrograde collateral, one of the epicardial collaterals. So at that point, we were wondering whether we were in true lumen, how big the dissection plane was, and then where we had re-entered the true lumen, whether we were going to lose that important PDA, because if we were true lumen, this would have been the RPA. So this is a case where we are able to gently balloon and deliver an IVUS catheter. I apologize for the IVUS images. We're using a Volcano for this procedure. But interestingly, the IVUS catheter showed that the wire distally was not only in the true lumen, but also that it had re-entered the true lumen prior to the takeoff of the PDA. So we didn't even need to resort to an investment procedure. We felt that we could safely stent into the distal RCA, avoid the bifurcation, and then get a good CTO PCI result. So the IVUS proved to be indispensable in this situation to give the patient an optimal CTO PCI. And this is what the procedure looked at the end. Again, the stenting was just done proximal to the bifurcation, and we're hoping that those vessels at the end, the PDA and the RPL, will remodel now that the CTO is recanalized. Now, there's also an evolution in antigrade dissection reentry. Previously, a lot of the strategies, part of devices like the Stingray, was in an uncontrolled manner, but there's now a push to use antigrade fenestration reentry to be able to achieve targeted wire-based recanalization of CTO PCI. And this procedure was initially described by Carlino and now further studied by Lorenzo Azzolini, who I thank for lending me these slides. So basically, an integration reentry relies on using one wire to enter the subintimal space, and then delivering a second wire into the distal cap of the CTO. This can be facilitated by a dual lumen catheter. Then there's delivery of a one-to-one balloon through the initial wire to essentially create transient fenestrations in the intima in order to create a channel into the true lumen. And then once this channel is created, the balloon is deflated, and through a microcatheter or polymer jacketed wire is advanced into the true lumen. And the reentry can be facilitated by the use of IVUS again to size the balloon, and also by the use of cutting balloons if you're having trouble creating those fenestrations. So this is a case that Lorenzo provided to me. So it's a CTO PCI of the mid-RCA. You can see that there's quite a bit of bridging collaterals in the mid-RCA, and then pretty good retrograde collaterals from the left system. Now, they used a Turnpike LP and Fielder XDA to try to traverse the CTO. And they were successful in getting distal to the distal cap, but the distal part of the wire was in the subintimal space. Now, in this situation, they would have to resort to dissection reentry or try to essentially reattempt antigrade wire escalation or use part of the wiring. But in this situation, they decided to go for antigrade fenestration reentry. So here, they've shown how they deliver a second wire into the distal cap of the CTO. That's shown on the left. And on the right, you see that they inflate a balloon one-to-one across the distal cap of the CTO to create those transient fenestrations. And then on the cine on the left, you see that now that the fenestrations are created, they're able to deliver a polymer jacketed wire, which in this case is Pilot 200. And they're able to get into the true lumen of the distal vessel as shown on the cine on the right. And after that, to complete the procedure successfully. Another option, as opposed to wire-based reentry, is to use device-based reentry. And traditionally, we've been using a Stingray, which I have found successful for a number of procedures, although I do find that this device can be difficult to deliver, particularly when there's significant calcification in the CTO. One modification that I've resorted to use, and I know that other operators are using too, is that the stick and swab has been increasingly switched for a stick and drive approach. I do find that sometimes when I use a high tip load wire to enter into the true lumen, I'm pretty convinced that I'm in the true lumen as per retrograde cines. But then at times there can be difficulties then inserting a polymer jacketed wire. So this stick and drive approach essentially consists of doing the stick. And once you feel that you've gone through the intima, you create a 180-degree twist in the wire and then advance the wire through the true lumen of the CTO. Obviously, this has to be done very carefully because if there's significant disease at the distal bed, you can actually extend the CTO. So it's a procedure that's more effective in cases where the distal bed is large and not diffusely diseased. Now, another increasingly used device is the Recross Catheter, which has a number of advantages compared to the Stingray. So one of it is that it has a port that includes a stylet, which makes it more deliverable. And it also has a core wire that makes this device more easy to deliver. And as a result, it can be used in CTOs where there's calcification. So essentially, there are two ports. So the stylet port leads you to an exit port about 8 millimeters from the tip.
Juan, can you wrap it up for the sake of time, please?
So this is just an example that I used that was lent to me by Sandra Kalra. So this is a CTO PCI of the RCA. A lot of calcification, difficulty entering the proximal cap. Sanjog used a Carlino technique to soften the proximal cap and essentially get into the subintimal space. But unfortunately, when he got true lumen, but didn't cross the distal cap yet. So when advancing his wire, he got into the subintimal space, distal to the CTO cap. And as you can see on the cine on the right, Sanjog delivered the recross catheter with the midport pointing into the true lumen past the distal CTO cap, and he used a judo 6 to poke through the intima into the true lumen, which you can see on the cine on the right, and then ultimately delivered a polymer jacketed wire, a Mongo, that you can see here delivering into the distal RCA. And here you can see the results of the final CTO. So take-home messages is that an Antigrade approach has evolved to a point that we can target more complex CTO PCIs. This is largely based on the use of IVIS to identify the proximal cap and points of reentry. But then more advanced wiring-based techniques to reenter the true lumen, as well as device-based techniques, can increase proceduralist success with an Antigrade approach, allowing a higher complexity of CTO PCIs to be targeted in Antigrade. Thank you.